All right. Hey, everyone, and welcome. If you're in nursing school, you know the kidneys can feel, well, super complex, right? Today, we're going to change that. We are going to totally demystify them. We'll take a deep dive into renal anatomy and physiology, and this is designed to help you not just ace that exam, but more importantly, to really get what's happening with your future patients. So let's jump right in. So here's our game plan for today. We're going to start with the big picture, the kidney's main jobs. Then we'll zoom way in to meet the nephron. It's the tiny little workhorse of the whole system. After that, we'll check out how it filters blood, how it refines that filtrate, and finally, how the kidney so brilliantly controls its own blood flow. Okay, first up, the kidney's master plan. It is so easy to just think of kidneys as the body's trash service, but honestly, their role is so much bigger, so much more critical to keeping us alive and stable. I mean, just look at this list. This shows you just how much the kidneys are juggling. It's way, way more than just filtering out junk. They are the absolute master regulators of our internal world. We're talking balancing fluids, electrolytes, or acid-base balance, you name it. And get this, they also act like an endocrine organ, pumping out critical hormones like renin for blood pressure and erythropoietin to make red blood cells. They're true multitasking powerhouses, for sure. All right, time for a quick knowledge check. This one highlights one of those functions that, kind of flies under the radar. So if your patient has been fasting for a few days, which organ really steps up to the plate to make new glucose? Your first thought is probably the liver, right? But in this specific case, it's the kidneys. That's an awesome clinical pearl to have in your back pocket. So, how in the world do the kidneys pull all of this off? Well, the magic really happens at the microscopic level. So let's move on and meet the real MVP, the functional unit of the kidney, the nephron. And no, that is not a typo. You have about 1.3 million of these tiny filtration factories in each of your kidneys. Think about that for a second. That number is just staggering, and it's absolutely the key to the kidney's incredible resilience. So let's put on our clinical thinking caps. Why would the body pack so many nephrons into one organ? What's the real-world advantage of having over 1 million of these little guys? And the answer is all about having a backup, a huge backup. This massive functional reserve means that a person can actually lose a pretty significant amount of kidney function, maybe from disease or an injury, before they even start showing any symptoms of kidney failure. It's like a built-in safety net. Now, not all nephrons are created equal. Most of them, about 85%, are cortical nephrons. These are your everyday workhorses, handling most of the excretion and regulation. But that other 15%, those are the juxtamedullary nephrons, and they're the specialists. See how their loops of Henle dip way, way down into the medulla? That super long loop is the secret weapon that lets the kidney make either really concentrated or really dilute urine, all depending on what your body needs. Okay, let's zoom in even further to the very first step in making urine, the glomerular filter. The best way to think about this is like a super sophisticated, high-pressure checkpoint that gets to decide what leaves the blood and gets into the nephron. This quote right here just nails it. This is the whole mission of the glomerular filter in a nutshell. The goal is simple. Let all the fluid and waste products pass through. But, and this is a big but, keep the important stuff, especially proteins, right where they belong, in the blood. So how does it do that? Well, as you can see here, this isn't just some simple coffee filter. Oh no, it is a complex 3-layer barrier, and each one of these layers has a very specific job. Let's break this down. First, the blood hits the fenestrated endothelium. Think of it as having little windows or pores that are big enough for plasma to squeeze through, but small enough to block all the blood cells. Next up is the basement membrane. Now, this layer is really clever. It has a negative electrical charge, which actually repels other negatively charged things, like the protein albumin, basically pushing it back into the blood. And finally, you have the podocytes, which form this outer wall with tiny little filtration slits, and they act as the last line of defense, catching anything that might have slipped through. So, knowing what we just learned about that barrier, here's a huge clinical question for you. You get a urinalysis back on a patient, and it's loaded with protein. What should be the first thing that pops into your head? Exactly. It's a massive red flag. It means that sophisticated 3-layer barrier has been broken. Seeing significant protein in the urine is a classic sign of glomerular damage or disease. It tells you that the kidney's main filter is failing. Okay, so once the filtrate makes it past the glomerulus, it's not actually urine yet, not even close. Now it has to enter what I like to call the tubular processing plants. It's this long, winding assembly line where the body carefully decides what to pull back in and what else to toss out. And the first stop on that assembly line is the undisputed champion of reabsorption, the proximal tubule. This is where the vast majority of the work gets done. Now get this, the glomeruli filter about 180 liters of fluid every single day, and this one section reabsorbs about 178.5 liters of it. It is constantly pulling back nearly all of your glucose, amino acids, and most of your sodium and water. It's just incredible. Next, the filtrate dives down into the loop of Henle, and this is where a really cool mechanism comes into play. Notice how the two sides, the two limbs, they work in opposite ways. The descending limb going down is super permeable to water, so water just flows right out, which makes the filtrate inside more concentrated. But then, the ascending limb going up actively pumps salt out, and it's totally impermeable to water. This whole setup, this countercurrent mechanism, creates an incredibly salty environment deep inside the kidney, and that is the key to concentrating our urine when we need to save water. All right, for our last section, we're going to look at one of the most elegant systems in the entire body, how the kidney basically has its own autopilot. It masterfully regulates its own blood flow and filtration rate, almost completely independent of what's going on elsewhere in your body. And this brings us to a term that you absolutely have to know, the Glomerular Filtration Rate, or GFR. As a nursing student, you are going to see this lab value over and over and over again. It is the single most important measurement of kidney function. It tells us exactly how well those glomerular filters are working. And since you're going to be seeing it all the time, you have to know what's normal. So, what do you think? What's a healthy GFR for a young adult? The normal range you want to remember is right around 115 to 125 milliliters per minute. Just let that sink in. That means every single minute, about 125 milliliters of plasma is being filtered into your nephrons. That's a number you'll definitely want to commit to memory. So, how does the kidney keep that GFR so incredibly stable? Well, it's through a process called autoregulation. Just look at this diagram. The kidney can literally change the size of the tiny arteries going into and out of the glomerulus. So if your blood pressure spikes, it'll constrict the in-pipe, the afferent arteriole, to protect the filter from that pressure. If your blood pressure drops, it can widen that same pipe to let more blood in. It is a beautiful, self-regulating system. But that elegant system does have its limits. That autopilot, that autoregulation, it starts to fail when the body's mean arterial pressure, or MAP, drops below about 80. So I'm going to leave you with this final thought, to really connect the physiology to your clinical practice. Knowing that the kidney can't protect itself anymore when the pressure gets that low, how does that perfectly explain why a patient in shock with severe hypotension is at such a high risk for an acute kidney injury? It's a critical connection to make. Thanks for joining this explainer.